Hi all, thanks for the introduction and also the invite to come to speak today. I do work at the university, but I'm also a vascular nurse consultant within the Mid-Yorks NHS Trust, so I'm still clinical 3 days a week. I've just wanted to come to talk to you today really, and my session's based on red legs and how you can get this complex diagnosis and to give you a little bit more skills and education to make sure that you're getting this right at every point of contact. So, red legs. What are they? Well, red legs can be an indication of a chronic illness, but it also can be an indication of an acute illness. It can also indicate a critical illness, and God forbid, it can also indicate sepsis, which could be a life-threatening illness. But to many of us out there, actually, when patients come in with us with red legs, it sometimes feels like a bit of a mystery diagnosis of where do you start. For many of you, the first thing that you think about is red legs. You will think about cellulitis. We know that cellulitis refers to a superficial spreading skin infection that's often started by the entering of a microbe within the skin structure. And that's an infection without the formation of pus, which is very important in terms of its diagnosis. The burden of cellulitis is actually quite massive. It accounts for 3% of all hospital admission, all attendances to A&E, should I say. The inpatient cost of treating cellulitis is up to £250 million a year. And this accounts for 400,000 bed days a year. And the number of cellulitic cases keeps rising year on year. But maybe not. Because cellulitis is up there at the top misdiagnosis. A third of all patients who's diagnosed with cellulitis do not, in fact, have cellulitis. If you think about this, this is a significant waste. It accounts for a waste of £84 million. It also accounts for 132,000 bed days. In today's NHS, where both money and bed days are of acute shortage, surely we need to do something about this to address this misdiagnosis. But for me, actually, the impact's even bigger than this. We're having inappropriate treatment with antibiotic therapies. This is a real issue. Antibiotics and their stewardship should be up there on each and every one of your practice. And there is a direct, private, wider public health risk to this. But for me, there's an even bigger problem. If the patient has got misdiagnosis, it means that they are not being correctly diagnosed. Therefore, they will not be having the most effective treatment. What does this do to your patients? The only thing that will result in is increased suffering. So, education about cellulitis, its causes, how to assess it, how to treat it is essential. All of these patients were referred to me with cellulitis. None of them have cellulitis. The first patient on the far right has got problems with moisture management. The middle picture has got signs of venous flushing because of his underlying venous disease. And the final patient has got contact dermatitis caused by an allergen and a latex allergy. We need to make sure that we're getting this right, because if we're not treating the appropriate underlying cause, we are failing our patients. So, how can you improve your diagnosis of cellulitis? Well, you can improve it like the way that you diagnose anything else out there. You need to take a careful history. That careful history needs to be combined with a physical examination. And you need to be confident about what are the signs and symptoms of cellulitis and what are the common mimics that are out there. Because red legs do not equal a diagnosis of cellulitis. So let's consider who's at risk of cellulitis. Well, the prevalence increases with the ageing population. I'll be careful with the word elderly because now I'm above 40, I think I'm getting closer to that category. We know that it increases with an ageing population because they have got more likelihood of having comorbidities and they have thinning of the skin. We know it also is a predisposing factor of being obese because we know that obesity affects your lymphatic and venous insufficiency and your lymphatic drainage. But the problem is with obesity, it also can impact on patients' hygiene of their lower limbs. We know that if you've got venous insufficiency or edema or lymphedema, all of that will increase your risk of cellulitis. But very interestingly, were you aware that having a vein harvest of your leg is one of the great predicting factors? So if you've had your vein removed to be used as a conduit for a CABG, a coronary heart bypass, or an arterial bypass of your leg, this is a predisposing factor of one day developing cellulitis. Unsurprisingly to you, that having a disruption of the surface of the skin, such as trauma and ulceration, and skin conditions such as eczema or athlete's foot, also predisposes you to having cellulitis. So who's affected? Well, men and women are affected equally. It's more common with the advance in age, but the most common predisposing risk is having one attack of cellulitis. If you've got a patient who's had one attack of cellulitis, they have a 20% increased chance of having cellulitis within the next 12 months. And this is because of the complex cyclic nature of having cellulitis and the impact that does in terms of your lymphatic drainage. So, what are the causes of cellulitis? Well, the main culprit is actually streptococci. There are some cases associated with Staphylococcus aureus. Remember that unlike staph, which is found routinely on your skin, streptococci shouldn't be there. It's not normally found on healthy skin. It lives perfectly, though, in any areas of cutaneous buildup or if you've got any areas of skin disruption. So it loves moist places. It likes a bit of athlete's foot. It likes areas of venous eczema. It likes anything that it can sort of get bedded down in and nice and moist in. It's very interesting if you look at streptococci and how it actually invades the layers of the skin. It can directly invade the layer of the skin where it is bedded, but streptococci is a fantastic microorganism. It can also climb from that area of contamination, moving to an area of vulnerability, climbing up your foot to find a leg ulcer, and therefore cause you problems in terms of cellulitis. And very interestingly, up to 80% of cases of cellulitis have got predisposed conditions interdigitally. In between their toes, there is often the presence of some type of infection, increased moisture, or some type of skin condition. How many of us out there are checking the patients interdigitally for each episode of cellulitis that these patients are getting? The presence of bacteria in wounds is not new. Mr. Kinsley, our lovely chairman, started talking about this when I first became a vascular nurse, so many years ago now. We know that these wounds are often contaminated, and we know that these wounds can move through a continuum of contamination, colonization, local infection, spreading infection, and systemic infection. When we're talking about cellulitis, we're talking about this final end of this spectrum, this systemic infection. And with a systemic infection, you can often get local and systemic responses. The first one that we often think about is fever. Fever, pyrexia, and tachycardia. But be careful with that one. It's not a simple yes or no, because up to 80% of patients with cellulitis could be afebrile. So using that as a distinct yes or no is not helpful in terms of your diagnosis. There is often spreading erythema of greater 2 centimetres margin, and there will be a clear area of demarcation between the healthy and the unhealthy skin, but this will be a clearly defined but irregular border. The limb itself may be showing signs of painful, warm to touch areas, and this is a simple result of the vasodilation that's happening as the response in terms of the microbes. Edema is often present, and you'll notice that the skin becomes quite shiny and quite swollen. And as this happens, you can often find this orange peel type effect, because as the edema sits within the subcutaneous tissues, it actually moves within the dermis. Therefore, wherever your hair follicles are anchored down to the base of the dermis, it doesn't allow them to expand. So you get this like orange peel type effect of the skin. And with this, it often finds that the patients are feeling generally unwell. They will report signs of feeling flu-like. They will report signs of feeling unwell generally, of general malaise. And be careful with cellulitis because it can develop rather rapidly. So once you've got the signs and symptoms in terms of a clinical investigation of what is potentially cellulitis, there's some really nice quick safety checks in terms of helping you decide is this true cellulitis or not. And the best one really is looking at the inflammatory markers within the blood. White cell counts, ESRs, CRPs are very, very useful in making that final diagnosis. But be careful once again, it's not a yes or a no response. Having a white cell count which is normal does not mean that this patient may not have cellulitis. 50% of patients had an elevated white cell count, but the other 50% of patients had a normal white cell count. ESRs and CRPs are much more sensitive. They are sensitive in the fact that you will find a spike up to 92% and 85% of patients will have an increased ESR or CRP rate on their inflammatory blood markers. But be careful of that because there's often other things that can also elevate them too. So it's not so easy, isn't the diagnosis of cellulitis? But what I think is really useful is that within the literature out there for you now is this. And I think this is a fantastic clinical safety check. It's out there, and I'll point to the actual document that it came through in a minute. But this is really good because it helps you to diagnose, is this cellulitis or not? But it also points out to you what are the other mimics that could be presenting and helps you to move that patient along the diagnostic pathway. Once cellulitis is established, we need to ensure that the treatment is correct. And we need to, at times it feels like we don't know how to treat patients with cellulitis. There seems to be a debate, are they suitable for oral antibiotics or do they need IV antibiotics? The evidence is out there of how these patients should be treated. This is a fantastic document that tells you how to grade the severity of cellulitis, but it also points to how you should be treating that patient. Should it be with oral antibiotics or should it be with further IV antibiotics? In terms of the treatment, the majority of patients do not require hospitalisation because of cellulitis. The majority of patients can be treated quite nicely with oral antibiotics at home. The most common of these being flucloxacillin, but there are some cases of using amoxicillin, clindamycin and ciprofloxacin. If the cellulitis is severe, then we may require IV antibiotics. But again, this does not in today's world mean a hospital admission. Many of you out there will have IV antibiotics at home teams, and these are the type of services that we should be putting into these patients. How interesting, though, that if you start to look at the evidence, a brief course of non-steroidal anti-inflammatories such as Brufen will help to shorten your treatment times and prevent the risk of recurrence. How many of you out there, if you've got established cellulitis pathways, include this important non-steroidal anti-inflammatory? This could give you very quick and easy gains. So, treatment. We must treat the cellulitis at the same time as addressing that predisposing factor. So if this patient has got edema, signs of venous disease, signs of lymphatic insufficiency, we need to be treating that at the same time by using compression therapy at the same time as antibiotic therapy. Remember to encourage antibiotic elevation because this will help to reduce your edema, but also reduce the inflammatory components within the blood. And please do not routinely stop compression therapy. It's a common myth that's out there that compression therapy is contraindicated in patients with cellulitis. This is not the case. Compression may need to be reduced if the patient cannot tolerate it because of the painful limb. The compression system may be changed to be able to get some type of compression on the leg that you are able to inspect the leg on a daily basis to see how it's responding to treatment, but it's not a direct contraindication to compression. In fact, it will help. We know that there is a clear link between cellulitis, lymphatic changes, periods of further cellulitis, and this cycle of change in deterioration. The use of compression during patients' active cellulitis can help to prevent all this from happening. But in patients that's had 2 or more episodes of cellulitis to the same area, you should consider the use of prophylactic antibiotics. But you need to do this only if you've sort of addressed their underlying factors. So have you had an adequate amount of compression on to reduce that limb volume? If you have and they've still developed cellulitis, prophylactic antibiotics can work. But if you haven't got that leg and that underlying predisposing factor under control, I would encourage you to focus on that area rather than the antibiotics themselves. But long-term low-dose antibiotics can certainly help to reduce the chances and recurrence of cellulitis. But what if it's not cellulitis? There's several mimics out there that give the same clinical appearance as cellulitis, and this can often lead to misdiagnosis and inappropriate management. This includes venous hypertension, dermatitis, lipodermatosclerosis, lymphedema, chronic limb ischemia, and venous obstruction. And I'd just like to take a moment or two to go through these with you. To me, as a vascular nurse specialist, this is the most common disease I see. Every single patient that seems to get referred to me has this in a degree or another. Venous hypertension is common. Please look out for this as a sign of having that changes, the mimicking of red leg in the lower limb. Look for those key changes. Look for visible varicosities in terms of varicose veins. That will give you an indication if this patient may well have venous hypertension. Look at that hyperpigmentation in terms of that hemosiderin staining. Look at those skin changes. If this patient does have areas of redness, this will not be warm to touch. It'll be relatively cool to touch. And this will not have a very clear demarcated border like cellulitis does. This does not need treating with antibiotics. This needs treating with compression therapy, venous imaging to see if there's any intervention that we can do to remove that venous incompetence and therefore prevent further damage from happening to the skin. Eczema and dermatitis go hand in hand with venous hypertension. I used to spend hours trying to distinguish between my mind what's the difference between eczema and dermatitis until a dermatologist told me there is no difference. Sometimes I think we use two terms just to confuse our juniors, but you can use these interchangeably, they mean the same thing. But this is often misdiagnosed as cellulitis. This is a crusting, weeping appearance of skin. It's often itchy. Cellulitis tends not to be itchy. There's an absence of heat with this. There's no true tenderness when you touch it or put any pressure on it. And it often appears in these net-like cracks, giving this vertical and horizontal appearance. This needs treating with topical steroids, and it needs treating with emollients. And if they have got a condition of underlying venous hypertension, again, it needs treating with compression therapy and venous imaging. But these patients with broken areas of skin have got a higher risk of developing cellulitis. So just watch that one with a little bit of caution. Lipodermatosclerosis is the chronic inflammation of the subcutaneous tissue. To me, this is the most common misdiagnosis for cellulitis, because in the acute phase of this disease process, the leg itself can become shiny, red, hot, swollen, painful, all of those mimics of cellulitis. But this often develops over weeks and months, not an acute episode. And over time, the heat will start to reduce out of the leg. To me, the most biggest indication of this not being cellulitis is this often occurs in both of your legs, not in a single limb in itself. Lymphedema in itself can cause skin changes, and it can cause changes in terms of the discoloration to the lower leg. And this is due to the protein-enriched fluid depositing within that subcutaneous tissue, and that chronic fibrosis turns that initial soft edema into some very hard, stubborn edema, where you eventually get skin changes in terms of papilloma formations. This will be hyperpigmentated, but again, it shouldn't be warm to touch. It should feel relatively cool to touch. Therefore, you're able to eliminate that cellulitis. So far, I've talked to you about options in terms of misdiagnosis. Now, if you misdiagnose cellulitis as any of those three that I've just discussed, all you're going to do is delay treatment of your patients. I say all, I still find that quite harmful. The next three that I'm going to talk about, though, the impact of this misdiagnosis is massive, because this misdiagnosis can reduce and increase risk to their limb, but also to their life. One of the things that's often misdiagnosed as cellulitis is critical limb ischemia. You can see this MRA picture. If you look on the right-hand side, they've got a complete occlusion within the iliac artery of the right. This patient has been presented with a sunset foot appearance, and that got diagnosed by the GP as cellulitis and put on flucloxacillin. This is critical limb ischemia. If revascularization does not occur soon, this patient will develop gangrene. To me, critical limb ischemia, though, is one of the easiest things to diagnose. You can all become mini vascular nurses. This patient will complain of irretractable, excruciating pain constantly, which is worse on a night time when they elevate their leg to go to bed. It's often on a background of intermittent claudication, that being pain when they've been exercising and using that muscle. This sunset red foot, if you are able to elevate the leg, you will see it drain away. The colour will drip out of this leg. If that discoloration was due to an infective process, it doesn't matter where you'd put the leg, that leg would still keep red. But if it's due to vasodilation, then as soon as you elevate the leg, this leg will turn pale in itself. Using those little tips in terms of elevating the leg and watching and seeing can really help to ensure that you're not making inaccurate diagnosis of cellulitis. But please remember one thing, we as vascular team call this critical limb ischemia. Now the word critical to me and you in a normal nursing environment means here and now. Critical limb ischemia does not require admission to a hospital here and now. Critical limb ischemia requires an urgent referral to an outpatient vascular centre, and that patient should be seen within 7 days of your referral. This is not a blue light get them to A&E. Unlike acute limb ischemia. Acute limb ischemia happens because of an interruption of the arterial supply. This can happen in fractures. If you've had a knee dislocation, it can happen quite frequently. If you've got a fractured neck of femur, this can happen. You can also get arterial thrombosis, just like you get thrombosis within the veins. This leg will appear initially red, but it will look mottled. This will be quick of onset. The patient will be in significant pain. They will tell you about the 6 Ps. If you can all remember when you were student nurses, you got taught about compartment syndrome. The 6 Ps were in there. So it's talking about pain, pallor, pulselessness, paresthesia, an inability to feel the leg, and an inability to maintain a normal temperature of the limb and the body. This is an acute vascular emergency. If you think a patient has got acute limb ischemia, this requires a blue light and an admission to a hospital within an hour of finding it. Please don't think as community nurses you'll never come across this. Our community nurses have come across this quite a few points of time. And it's having that education and that skill and that wider arching knowledge that hopefully you're gaining from us today, that you're going to be able to make sure that you're that safe practitioner. And the final one is misdiagnosis, is acute venous obstruction, or DVT to me and you. We have so many patients, especially if they're in an inpatient ward. It's remarkable how many referrals we get as a vascular team for cellulitis when the patient is 5 days post-hip or knee replacement. And you are instantly asking, have you excluded a DVT in this patient? The limb will appear congested. There will be colour changes, but there will be an increase in pain when the patient flexes their foot, and this will be of sudden onset. Look out for those careful triggers, because often DVT is preceded by an event, a long-haul flight, some type of surgery, a changing their mobility, having a fracture and wearing a cast. Asking all of those questions will ensure that you're getting the diagnosis right. So, to summarise, there's some really quick checks in terms of cellulitis. Cellulitis really only occurs in one leg. You have to win the European lottery to get bilateral leg cellulitis. So if it's bilateral redness in both your legs, think again, this is probably not cellulitis. Check the bloods, concentrate on the CRPs and the ESRs, that'll help you in terms of making that final diagnosis. Get the leg, elevate the leg and watch it. If the colour drains from that leg, it is not cellulitis. Look at the whole of the leg. You are very unlikely to get cellulitis from your toes to your groin. If you have that, it's much more likely to be some type of obstructive disease in terms of venous obstruction or arterial obstruction. This should be rapid onset from cellulitis. If the patients are reporting discoloration of their lower leg for the last 3-4 months, this is not going to be cellulitis. Think again. If a patient's just had a course of antibiotics and there's been zero change to that area of discoloration, recheck that diagnosis, think again, are you sure it was cellulitis to start with? Always consider the underlying factors and treat these in combination. So if you've got venous disease, lymphatic disease, these patients should be in compression to help manage the cellulitis and prevent the risk of onward occurrence. do me a favour, have a read of some of this amazing documentation that's out there. The CREST guidelines are the best thing ever in terms of cellulitis. It's my level reading. You can read this on a night time. It's easy to read Jack and Jill stuff that'll help to change your processes. This paper that's on here about the 10 top tips is the one where you can find that cellulitis checklist. I love that checklist. I don't do it physically, but it's in my brain in terms of how I should be diagnosing cellulitis. So remember, all patients deserve an accurate diagnosis to ensure they've got the most appropriate treatment. We need to use antibiotics wisely. They are not an infinite resource. So remember, be a bit of a mystery solver to make sure that you're providing the most possible, highest level of care you can. Thank you.